Hello, my name is David Murray. I'm the Associate Director for Prevention and Director of the Office of Disease Prevention at the National Institutes of Health. I'm pleased to welcome you to the final of 3 2023 ODP Early Stage Investigator Lectures. We created this lecture to highlight early career prevention scientists who have not yet served as a principal investigator for a substantial NIH-supported research project, but who have made outstanding research contributions to their respective fields and are poised to become future leaders in prevention research. Before we begin, I have some housekeeping items. First, you can submit questions during the webinar via the chat pod. You'll need to open the pod by hovering your cursor at the bottom of the Zoom window and then clicking on the chat icon. Please direct your questions to hosts and panelists. We will open the floor to questions at the end of the lecture. Second, the slides and video recording will be posted on our website in approximately 2 weeks. You'll get an email when those materials are available. We're excited to present our third 2023 awardee, Dr. Rodrigo Carrillo-Larco. Dr. Carrillo-Larco is an associate academic research scientist at Rollins School of Public Health at Emory University. His research seeks to bring big data sources non-traditionally used in epidemiological and public health research together with novel analytic approaches to provide timely and pragmatic evidence as well as tools to solve problems in global health. Most of Dr. Carrillo-Larco's work has been about primary prevention of noncommunicable diseases, particular cardiovascular disease and diabetes. Today, Dr. Carrillo-Larco will describe selected features of cardiometabolic epidemiology for Hispanics, global and international comparisons, as well as recent advances and opportunities for risk-based prevention of non-communicable diseases. Please join me in welcoming Dr. Carrillo-Larco.
Thank you so much, Dr. Murray. Thank you so much to everyone who has joined us today for this presentation. I also look forward to your questions at the end of the presentation. So I will be talking about cardiometabolic health and cardiovascular prevention, mostly for Latin populations. We have some comparison with global estimates with other regions, and I will also share some of our work about prevention, primary prevention of cardiometabolic diseases. So first of all, no special disclosures, no conflict of interest. I made this presentation myself. Most of this work was previously funded by the Wellcome Trust, and a huge thanks to all members and the steering committees of 2 global and regional data pooling projects that have made this work possible. Most of my work has been population-based, reducing data sources from population-based studies. So also huge thanks to everyone who decided to participate in these population-based cross-sectional surveys, national surveys, as well as epidemiological prospective cohort studies. The presentation today will have 3 main parts. First, I will start describing some features about cardiometabolic risk factors. Then I will move on and discuss cardiovascular outcomes, cardiovascular diseases. Then I will share some of our work about improving the prevention and the monitoring of cardiovascular and cardiometabolic conditions. And finally, some conclusions and ongoing work with different areas and different data sources. So to begin with cardiovascular risk factors, I will be discussing about 2 main risk factors. And the reason I chose those, first of all, systolic or blood pressure in general, is because we do have effective treatments to decrease blood pressure, to improve hypertension care, and achieve, ideally, hypertension control. On the first plot on the right, we have estimates of mean systolic blood pressure for every region in the world. We have men on top, women, and the second part of the plot. And in these red boxes, we have Latin America and the Caribbean, the whole region. And the key thing that we can take from this plot is 2, actually. First, that for men, we haven't actually seen a big reduction in mean levels of systolic blood pressure, and this is taken all out of population, 18 plus years. For women, well, we saw a decrease let's say between the 80s and the early 2000s, in the last 15, 20 years, we are no longer observing a decrease. So actually, it's been stagnated. We see a plateau in terms of systolic blood pressure for Latin populations, for both men and women. So that's not ideal. Even though we have effective treatments, even though we know much about how to prevent hypertension, how to reduce blood pressure, both at the individual level with treatment, as well as at the population level with interventions and policies, we are still not doing a very good job. And we still probably need additional tools that will help us achieve a much sustainable and stronger reduction. And the other key thing that I wanted to share with you is the huge diversity or heterogeneity in the region. As we can see from this map here, this again shows mean systolic blood pressure for, in this case, only men 18 plus years. And we see a couple of, one country with very red color, meaning very high mean systolic blood pressure. And we see other countries in a combination of oranges, sort of yellow, light greens, and other countries more in very, very green color. That we could say it goes from about 120 to about 130 or 135. So like 15 millimeters of mercury of difference between countries that are very close to one another, that could share genetic ancestry, that could share the same limitations in terms of access to healthcare, of access to preventive healthcare. They could share also diet and other modifiable risk factors. So not ideal trends, huge diversity or heterogeneity in the region for systolic blood pressure. Of course, when we think about systolic blood pressure, we always do so thinking about hypertension, which is arguably what we most care in terms of prevention and thinking from a health perspective, because that's the diagnosis we make, that's what the disease for which we give treatment. We don't usually base our clinical management on absolute mean levels of a risk factor, but on absolute terms of yes, no, has the disease or no. And again, on the right-hand side of the slide, we have every region, and we have Latin America in these red boxes. And this plot shows like women on top, men in the second part of the plot. This plot shows everyone with hypertension, how many of them or what proportion of them have been diagnosed, or what we call aware, disease awareness, how many are treated, disease treatment, and how many, what proportion have actually achieved blood pressure control. And we see that in Latin America for women, that's about 35%. For men, it's about, let's round it up to 25% as well. So we, again, even though we have effective treatment, and treatment for high blood pressure have been around for many, many years now, it's not a new treatment, and there are a huge diversity of medicines available. Not only that, but a handful of medicines for hypertension are also part of the essential list of medicine by the World Health Organization. So there are many tools in place to have effective treatment delivered to people who need it. But we're still not doing it. We are still not doing the greatest job in this part. And when we see at each country again, we also observe diversity, heterogeneity, with one country doing quite well, here in Central America with a very blue color, and a few others doing not so well with very orange and very red colors, meaning this has a high proportion of people achieving hypertension control. However, a few other countries are not having a high proportion of people with hypertension achieving control rates. So we could say we have tools, meaning treatment. We know how to diagnose this. One of the issues is actually how do we make the diagnosis, or how do we make the decision who receives treatment for hypertension? And recent guidelines, probably since the since 2013 and so on, all also suggest deciding treatment for hypertension based on the absolute cardiovascular risk, not only in terms of my absolute levels of systolic and diastolic blood pressure, but in terms of my absolute cardiovascular risk. And I will discuss about that a little later. That is a key thing that we need to have in mind, because for the absolute cardiovascular risk, we need tools. We need tools that will tell us my absolute cardiovascular risk and the absolute cardiovascular risk of the patient I'm looking at the moment. So that's blood pressure. Again, for blood pressure, we have treatment. The treatment options have been around for many, many years. We should probably be doing a better job than we are doing today. Another modifiable risk factor for which we also have treatment is high cholesterol, specifically high LDL cholesterol, for which we have the very well-known medicine, the statins. And okay, as statins have been around or have been in the market for fewer years than antihypertensive medication, but still at least 20, 25 years now, if not more. But in Latin America, and as we can see in these red boxes, we have the first plot for women, the second part for men. This one shows all adult population, 18 plus years. And these plots are showing the difference in mean total cholesterol between 1980 and 2018. The bigger the arrow, the greater the change. It could be a reduction if the arrows are pointing to the left, or it could be an increase otherwise. However, for Latin American subregions, as we see in these red boxes, the arrows are very, very small, if anything, like in this case. In other words, they have not been a very huge change or a substantial change, arguably not a clinically or public health meaningful change in mean levels of total cholesterol in many regions, in many subregions in Latin America. And of course, we can make the same conclusion or observation for all the regions in the whole world, as we can see in this map here. And just in case, all the references are at the bottom of the slides. This comes from the NC risk factor collaboration. You can find figures in the website, and you can also find specific results for countries. And corresponding academic paper is also cited at the bottom. And again, as we discussed for blood pressure, we see a huge heterogeneity. We see countries very red, we see countries quite pink, and we see countries quite green. So huge difference between countries, not so much as we saw with blood pressure or hypertension, but still differences in the same region and within sub-regions, even though they could share a lot of the determinants or risk factors for high blood pressure, and in this case, for high cholesterol. So I was discussing is that we may still need some additional tools that will first point us to the right patients or to the right people who actually will benefit the most for treatment. Understanding that in a real world scenario, we cannot provide treatment for every patient because of limited resources, either in terms of screening or because of still an ongoing process of universal health coverage. Or there's also a major role that patients play, which is about adherence and taking their medicine as they should. So we could actually argue that we still need some tools that will make us first identify the right people, but also help us monitor how we are doing in terms of mean risk factor levels, as well as control and treatment gaps from a public health or population health perspective. So that's about cardiometabolic risk factors. Let's go to the other extreme of the distribution. On one hand, we have risk factors, things that will make us more likely to experience a disease, in this case, a cardiovascular disease or cardiovascular outcome. And now let's go all the way to cardiovascular outcomes, to the actual disease, to the thing that could lead us to experience disability, a great disease burden, and unfortunately, also mortality. And the same profile we observed for blood pressure and cholesterol, we can actually see for mortality, for cardiovascular death rates. This plot here on the right shows the number of deaths, the rate death actually per 100,000. And this line here is for the Americas region as a whole. And we again observed that since 2010, 2013, 14 or so, that decreasing trend is no longer going down. We see actually a plateau or a stagnation of the decreasing trends of cardiovascular death. That has been going on for the last 10 years or so, or even a bit more, perhaps. And our conclusion at the time was, again, probably we need something. We've been doing something really good from the 1990s to 2010 that took us from here to here. Now we need something else to keep the momentum going on, to keep this decreasing trend and takes us to even fewer deaths or fewer cardiovascular events. We need something to give us a hand in that job. And even though we have nice or global estimates that are very important for us to set targets, that are very important for us to monitor the disease, and they're very important for us to see how well we're doing and where we actually need to make changes or adjust things to improve. We can actually also make the case that in terms of research, that in terms of epidemiological research, we still need some help, or we still need some additional studies that will help us characterize better some risk factors in Latin America, some disease outcomes in Latin American populations. This plot here, for example, can come from a systematic review we conducted last year. And it was a very simple question. It was about the incident rates of a stroke at the population level in different countries in Latin America. Again, I think it's a very simple question. Incidence, we could say, quote unquote, just a cohort study where we follow people and see how many of them experience diseases. Latin America is a huge region. We have about 35 countries in Latin America and the Caribbean. But nevertheless, we found about 10 and 11 papers, actually 11 papers for incidence and 30 papers for prevalence, lifetime prevalence or point estimate prevalence of the stroke. So there are still some questions we could answer for specific populations, for specific risk factors, and for specific environmental risk factors that could change quite dramatically from one country to the other and from one population to the other from Latin population, from Latin ancestry. Okay, so far we've discussed the problems. No, we are not doing great to reduce blood pressure or achieving hypertension control. Same thing for cholesterol. We can definitely improve there. We are still not doing great in keep on the reduction in cardiovascular mortality. So we need solutions. We have looked at the problem. There are solutions we can actually implement. And I always like to divide the solution in two big groups, which are actually complementary. They do not compete against each other. It's not that we need to either choose population-based strategies or risk-based strategies. They complement each other. And this is a key, very important concept. If we look at population-based strategies, we have two very nice examples that are very much in fashion these last 5, 7, 10 years. First, for example, taxes. Taxes on unhealthy food. The first map here shows the number of the countries where there are taxes on sugar sweetened beverage. Not the best beverage for us to take health-wise. And the second figure here shows a study in Peru where they, at the population level, in a whole community, they change the usual salt they take for cooking and for making their meals and replace it for potassium-enriched salt. At the end of the trial, the observation was a reduction in mean levels of systolic blood pressure as the population, reduction in incidence of hypertension and the same population. And this is, of course, not new. There are plenty of similar trials, meta-analysis, and in general, reduction of salt, sodium is associated or may lead to reductions in cardiovascular outcomes, cardiovascular events. So these are two examples of population-based interventions, policies or things we actually deploy to the whole population, to the whole group of people in a community, in a county, in a city, and so on. But then we also have the risk-based approaches, which actually tells us to focus on the individual, on someone who is at high risk of experiencing a cardiovascular disease in this case. But the same concept could apply to all the conditions. But the risk-based approach is an individual-based approach, whereby we apply some tools that helps us quantify and say, this patient, this person is at high cardiovascular risk, and therefore could very much benefit from a specific treatment to lower blood pressure, lower cholesterol, or other treatment that may deem necessary for that specific patient. And again, I want to emphasize these are complementary approaches. We should not go with one alone. They go hand in hand, and the population-based are policy-based, intervention-based, community-based, and there are a group of people who work in that. And then the risk-based approach perhaps is most useful or more discussed from a clinical perspective, where I have contact with one patient only at a time, and I could use this risk-based approach or risk-based tools. And for the risk-based approach, I need tools. I need a formula, I need an equation, and it's something that will actually tell me, is this person at high risk or not? And we are perhaps very, very familiar with these kind of tools, which often receive different names: cardiovascular risk score, cardiovascular risk equation, risk model, and so on. And we have been around these models for many years, back since the 60s with the very first one developed using the Framingham study, most recently to 2013 or 14 with the pooled cohorts equation for cardiovascular risk prediction. So these are actually not very new tools, but are very effective. So we ask ourselves two things. First, are there any cardiovascular risk score for Latin population? Because you also know that a risk score developed for population A may not work very well for population B. So we, unfortunately, even though these tools are, no matter how well they have been developed and validated, they may not be ideal for a different population without recalibration or without a comprehensive analysis to identify, yes, it works well or it doesn't. And the second question was, if there are no actual risk score for Latin America, how do the available models perform? The answer for the first question was no. There were no models developed for specific Latin populations, not in countries from the region, and not for migrants living in other countries, migrants that came from any Latin American country. We did not find at the time in 2019, we did not find any models specific for this population. And the models that were available and that researchers have tried or tested in their populations were actually all over the place. Some work all right, some work not so well. The examinations of the models were not always ideal. For example, they will use different outcomes, or they didn't have all the predictors, so they just left one out, and so on. So from a research perspective, there was a huge gap because the available evidence was not so great. And from a pragmatic perspective, there was still the need to have one of these risk prediction models for cardiovascular diseases that will perform ideally really well in these populations. With that in mind, we said, all right, look, we need actually one of these prediction models for Latin America. And even though previous researchers have done a terrific job, that's not enough. That was not enough at the time. And we identified a series of limitations, basically two major limitations. First, cohorts, we need cohort study. That's for a fact, that cannot be changed. Some individual cohorts in some countries were, let's say, smallish, a few thousand people, or did not have a very long follow-up. So we would not have enough number of outcome events to predict, either because cohorts were small or the follow-up was still not very long. So we have to come out with a solution. And the solution we came out with was to actually convene what we later call ESIL, the Cohorts Consortium of Latin America and the Caribbean, which basically is a cohort data pooling project, meaning that we worked with individual researchers in different countries, collected their data, pulled their data together, harmonized all the data with two key ideas in mind. First, to identify and study the basic association between cardiometabolic risk factors and cardiovascular outcomes, and if there were any differences in the region compared to other world regions, whether we can use this as specific estimate for Latin America to improve disease surveillance metric. That was our first aim. Second aim, or our second target, was use this huge data resource to actually develop a new cardiovascular risk score specific for these populations. This map here comes from our very first publication. It is a little bit out of date today. We have a few more cohorts, a few more observations, but basically we pulled together cohort study, population-based cohort studies from 13 countries in the region, about 175,000 observations or individuals. And the average follow-up was about 8-9 years across all these cohorts. The map shows where we have cohorts from, where countries, and how many cohorts and how many observations we have from each of these countries. Today, the collaboration has about 75, 78 members, active members. So the first thing we ask ourselves is the association between cardiometabolic factors in cardiovascular diseases the same in Latin America as in other world regions? This seems to be a very basic question, a very epidemiological basic question. And the reason we ask ourselves that question was, until this work, most of these risk estimates came from cohort studies in North America, Europe, and some parts of Asia and Oceania, but largely leaving out cohorts or populations from Latin America as well as from Africa. So we came up with the age-specific. In this plot, we have on the y-axis age groups, on the x-axis relative risk between body mass index, glucose, systolic blood pressure, and total cholesterol for both fatal and non-fatal cardiovascular outcomes. The red dot shows our estimates, meaning the estimates computed from the Latin American specific cohort study. In gray, we have the results from the most comprehensive meta-analysis of cohort studies available at the time, which again basically pulled or included cohorts from North America, Europe, and some parts of Asia and Oceania. Largely, what we observed, was glucose, systolic blood pressure, and total cholesterol. The association was very similar. It was actually very, very similar, a lot of overlapping. For BMI, on the other hand, the association was slightly smaller, or the magnitude of the association was slightly smaller for Latin American populations in comparison to other world regions, specifically for people in their 50s, between 45 and 64 years, where the estimates were the most different. So to answer our first question was, for 3 of the 4 cardiometabolic risk factors, the association is largely the same in Latin America as in other countries, as in other regions. For BMI, not so much. This, of course, is an interesting finding from the epidemiological aspect, but also have pragmatic implications, meaning that risk estimates, such as relative risk, are used every day for disease surveillance, for disease burden metrics. For example, to estimate how many deaths are attributable or can be explained by high levels of BMI, glucose, systolic blood pressure, and total cholesterol. So we use our own risk estimates to quantify how many cardiovascular deaths are attributable to 4 of these main cardiometabolic risk factors: BMI, systolic blood pressure, total cholesterol, and non-HDL cholesterol. And across regions, sub-regions in Latin America for both men and women, we observe about the same pattern, but with very different magnitudes. First, systolic blood pressure is the #1 responsible for the most cardiovascular diseases. That's consistent across regions, though the magnitude changes quite a lot. In the Caribbean, for example, it goes from 180 per 100,000 persons year, whereas in the Andean Latin America, it's only about 70 per 100,000. In second place in the ranking, we will see non-HDL cholesterol, and also a bit of variability across regions. When we zoom in and look at the individual countries, we also again see huge diversity, and it's very, very evident for systolic blood pressure. Here we have on the left men, on the right women. This is crude attributable death rates per 100,000 people. BMI in the inner circle, systolic blood pressure, total cholesterol, non-HDL cholesterol, and countries. Countries are grouped within sub-regions in Latin America. If we focus on systolic blood pressure, for example, we see pretty much every color in the scale, from very, very dark blues to very, very greens, shades of greens in a few countries. So it's pretty much the whole spectrum of in the scale of colors. As I mentioned before, for systolic blood pressure, cholesterol, our risk estimates from Latin American populations were not very different in comparison to other world regions. So when we compare these numbers, or this number of attributable death, against current and available metrics, there were many, many big differences. But when we compare the estimates for BMI, we did observe difference, implying that the estimates we calculated based on our risk estimates were smaller in comparison to the global evidence available at the time. Mostly, for example, by the global burden of disease study. And then we did the same experiment for the same analysis for diabetes as a diagnosis, not according to continuous levels of glucose. And we observed that between 1990 and 2019, we have men, women as well. Light blue is 1990 and dark blue is 2019. In many countries, although not a very huge difference, the number of attributable deaths has increased. So that was our first question. That was our first set of aims and first set of contributions we wanted to make with the huge set of cohort studies that we have pulled together. We actually improved disease surveillance by delivering risk factors, risk estimates specific for this population, computed the number of attributable deaths that can be used for to set targets, to set goals for disease monitoring, and so on. And the second one was at the individual level. First one, population level, second one, more at the individual level, with a cardiovascular risk score, a risk calculation, a risk equation. It receives many, many different names, but in essence, it's a tool that will tell me the absolute risk of an individual to experience a cardiovascular disease in the next, oftentimes in the next 10 years. Again, this is not a new concept. There have been many, or there are actually many, many risk scores, and we have a selected list of key examples. In green are those that have been developed for specific countries. We are very much familiar with the Framingham version, different versions with the blue cohorts equation, and the key risk is for the UK. In purple, we have the models that have been developed for specific regions. The score is for Europe, and you have different versions for different countries in Europe. There was an early version in 2003, and last 2 years ago, now they came out with the second version. There are actually many models. Systematic review conducted in 2013, 10 years ago, actually found 363 models. So we actually ask ourselves, do we need one more for this specific region? Why and needed? And the answer we actually agreed on was yes, because none of those huge models that are very popular, and none of those 363 models were developed in Latin populations or for Latin populations. And we know that models developed for a different population will not work, will not be very accurate in a new population. So we went on and developed a new cardiovascular risk score for Latin American populations using the cohort studies that we pulled together. We developed two models, lab-based and office-based, acknowledging that even access to basic tests like total cholesterol may not always be possible in many instances, in many settings, rural settings, low income or low resource setting may not have even a basic metric of total cholesterol. So the office-based replaced total cholesterol with body mass index, which is arguably a much simple metric to measure. Our model performed well in internal validation, overall well, a discrimination of about 72%, and a calibration and an excellent calibration in men, and a good calibration in women, as we can also see from the calibration plots. An ideal calibration, it will look like every dot, every point is exactly on the 45-degree line. It's almost a case for men, and for women, we also see a very good calibration, not so much for the very high risk, but it still was very nice. Of course, developing and validating a new risk score is not good enough. We actually needed to say, okay, is this better than available tools, or is this not better than available tools? So we went on and compared our model with two models that are currently suggested in a number of different guidelines and clinical recommendations. This is our model in purple up here, the one I showed in the previous slide. And this is the original global risk, which is a model which was developed and recalibrated for every country in the world, or for 2006 countries. And in red, we have the model developed in 2019, and which is now suggested or recommended by the World Health Organization in a number of guidelines, specifically in the HEARTS package for prevention of cardiovascular disease. When we apply those models to our populations, these models did not work quite well. The global risk was probably all right, but the other model was still not very well calibrated. So in general, our model specifically developed with data from Latin American populations only was performing a bit better in this target population. As I said, we have two models, and then we use data estimates, mean estimates from each country, together with death and non-fatal events from each country to recalibrate our model. We basically changed some of the pieces in the model to make them more specific for each country, for each of the 31 countries in Latin America for which we had data. So not only did we have a new model, but we made it a specific for 31 countries, and we developed this risk chart, which may seem like a rudimentary version. I do agree, but again, it's not always possible to have internet connection or a mobile app or these kind of models integrated into electronic health records in many settings. For research purposes, we also developed an R package, a package for the statistical software R, where you can use this model for research and make it really simple. So risk prediction models can be, the use of risk prediction models is very evident at the individual level. For us to make decision treatments and to identify and classify people in terms of low, intermediate, high risk, that at the population level, we also have a very strong use of risk prediction models. For example, to identify treatment gaps. Basically, how many people should be receiving treatment based on guidelines, people above the threshold that are actually receiving or not receiving treatment. And this work is from ongoing analysis, where we're looking at the proportion of people according to international guidelines based on following the risk-based approach, the proportion of people who are actually receiving treatment for hypertension. And we have on the y-axis countries, and the x-axis proportion from 0 to 100. And the lines in red are countries where less than 25% of the population are receiving antihypertensive treatment, orange between 25 and 50, and green above 50%. So again, here's diversity. If sometimes fewer than 25% of the population are receiving these medicines based on the risk-based approach, they are arguably very effective and perhaps should be available in most places. So just a couple of final slides and new challenges or new avenues we are taking recently. First, population-based phenotypes, which are basically subgroups of population that share some specific characteristics. And the reason this matters is because those specific groups can be subject of a specific intervention. If I have group A and everyone in that group shares this profile, probably could give them an intervention to improve that profile and expect the best outcomes. In contrast, I could have group V, and the members of the group share a different profile, and I could give them a different treatment, a different intervention, and expect the best possible outcomes. So we are doing that again at the population level. We are using national health surveys and other national population-based surveys. And an interesting finding as well is that these phenotypes or these subpopulations are not static in time. So for example, if we look at some of our results for Chile, we see that this phenotype in green back in 2003 was about 43 of the population, but today, or in the latest survey in 2017, it's just about 20%. So phenotype or membership to the phenotypes change in time as well. The digital biomarkers. Our work on digital biomarkers has also focused at the population level to provide pragmatic evidence for disease surveillance. For example, we discussed briefly about salt consumption, about sodium consumption, which is an established risk factor for cardiovascular diseases. However, measuring sodium consumption at the population level is sometimes expensive, difficult. You need urine samples, ideally 24-hour urine sample, which may be complicated at the population level, expensive, burdensome, and not every survey can actually do that. So we thought, can we make a proxy? Can we make a digital biomarker that will help us quantify the mean levels and the prevalence levels at the population level using only data that is most readily available? And by that, I mean, for example, variables such as age, sex, smoking, blood pressure, weight, height, that are often measured in many health surveys, many demographic surveys, and so on. And when we applied a number of machine learning algorithms, and what we observed was that that computed digital biomarker, as we can see here in the blue dots, sometimes, most of the time, give a very similar mean level of salt consumption at the population level in comparison to the observed actual measurement based on urine sample. So we can use this approach to provide data, provide evidence, provide basic statistics in places where these are lacking and where we cannot actually have the ideal gold standard measurement for a number of reasons. And finally, we are also working about the SDGs, the Sustainable Development Goals. They have been around for a few years. They are due in 5-6 years now. So I think we also need to look at this and come up with numbers, come up with strategies, come up with surveillance metrics that help us identify how well we are doing. Are we on track? Are we going to meet the targets or not? And what needs to be improved to actually make and achieve the targets? This example here is looking, for example, at SDG 3.4, which looks at the decrease, which aims to decrease the number of deaths attributable to cardiometabolic conditions. Here we look at each of the states in Peru, in the country Peru. So these are subnational estimates, which are always very important as well. Mainly, perhaps, among other reasons, because decisions, interventions, policies, resources, budgets are always allocated or available at these smaller divisions. Not everything, not all the decisions, not all the policies get to be made at the national level. So it's always worth taking a peek at how each small part of the whole is doing. And what we found was that even though most of the conditions included in the target are going in the right direction, mortality to this, because of these conditions, is actually reducing. That's not the case for diabetes. In most cases, as we can see highlighted by the red arrows, diabetes is going in the opposite, arguably in the wrong direction. Sometimes it is the only disease going in the opposite direction, and other times there are other diseases going in that direction, but diabetes is actually or represents a large proportion of that opposition. So just to wrap up, I think we have shown that Latin America is an heterogeneous region between countries, within region, And the same can be applied to people coming or migrating from one or many of these countries. They have different exposures, they have different habits, they have different access to healthcare, they have different conceptions about what disease, illness, well-being might be, which make it a challenge to provide care, healthcare, and well-being for this population. Even though we've gone a huge way to have many improvements in research and epidemiological research, we still lack not so much today after all the work, but we're still lacking some simple and standard tools for risk stratification. We gave the example of cardiovascular diseases, but the same can be applied for other diseases and other emerging diseases in the field of non-communicable diseases. This still need to be fully incorporated into clinical guidelines and for disease surveillance. Large data pooling consortia are feasible. They do provide very good data, very large data for estimates at the population level in huge regions, including many countries. And this data and new technologies, new analytical approaches are offering new opportunities to solve and provide new answers for old, new, current, and emerging research questions. So I'm very happy to take any question. I do appreciate you taking the time to join us today, and thank you so much for your attention.
Thank you, Dr. Carrillo-Larco. Very interesting. First, I want to commend you on taking the initiative to ask the question, do we have risk scores? Do we know what the risk relationships are in Latin America and the Caribbean relative to other parts of the world? And the answer was no. And so you then set out to create this consortium of cohorts. I'm sure that was a huge undertaking. And then you've been able to look at the relationship between the risk factors and health outcomes, cardiovascular disease outcomes in Latin America and the Caribbean, and to compare that to other parts of the world. So a huge amount of work, and really quite remarkable to have done all of that. So some specific questions. One of the striking findings was that the relationship between BMI and cardiovascular disease was not as strong. The risk was lower, particularly among younger adults. There was also some evidence that the relationship between cholesterol and risk of heart disease was lower in younger adults. What might explain the differences that we see in the Latin American Caribbean population compared to North America, Europe? What are your thoughts?
Thank you so much for the question. And yes, that was definitely something we thought a lot about. We did have some hypotheses to try to explain that. One was the amount of time people in Latin America have been exposed to the negative effects of obesity or high BMI. So in some countries or some regions, the prevalence of obesity was high back in the 80s, back in the 70s, or the trend was already increasing. In Latin America, the prevalence of obesity was increasing a bit later. So we could argue that people in Latin America or from Latin America have been exposed to the obesity epidemic for fewer years and therefore accumulated less the negative effect of obesity, adiposity, and so on. So that was one hypothesis. And the second thought we had was it had to do with the distribution of the obesity in the body, whereas it was centrally distributed, whereas it was inside the perivascular, periliver, pericardial fat. It was in the muscles. And so the distribution of where my fat is may be different between countries, between regions, between populations, and that could also explain some differences in the risks.
Do you think that the same issue, at least in terms of how long the exposure has been going on, might apply for cholesterol.
Most likely, yes. Most likely, yes.
Very interesting. The most important contributor to cardiovascular death from your data in Latin America and the Caribbean was elevated blood pressure, elevated systolic blood pressure. What are countries in those regions doing about blood pressure? Are they aware that it's the major driver? Would you advise them to focus on blood pressure because it seems to be the major driver?
Yes, I do think they are totally aware of the fact that blood pressure is leading driver. I know there is a massive work going on across the region led by the Pan-American Health Organization and national partners, national teams, national researchers to implement the HEARTS package, which is a set of clinical guidance and recommendations and algorithms developed by the World Health Organization, and in this case by the Pan-American Health Organization, to identify people at high risk, to provide them with treatment. They have options, for example, for community health workers or other non-health professionals, personnel who could also actually step up and do some of this work or provide help in this work. So that's a very massive undertaking that have been going on for the last maybe 5 years, 3 years. And of course, we haven't seen any changes yet because it's just too early in the implementation of this program, but I'm sure it will have a huge impact in improving hypertension control. So far, they have been focusing on blood pressure and hypertension, and I think at some point we will have to also incorporate cholesterol and cholesterol management following some similar guidelines and some similar recommendations. But perhaps a limitation there is still access to statins or medicines, even though they have been around for 20 years now or more. They're still sometimes not very, they're still sometimes quite expensive or not very available across the board.
You saw considerable heterogeneity among countries in Latin America and the Caribbean in the relationship between risk factors and cardiovascular outcomes. Do you have thoughts about why there is so much heterogeneity? And does that suggest that you need to have country-specific risk scores and models? So let's see what your thoughts are there.
Yeah, I mean, that's an impressive finding, surprising and quite challenging as well, because yes, there are huge heterogeneity in terms of risk factors and cardiovascular outcomes. Reason for that, very diverse, from elemental risk factors such as diet, physical activity, access to this, access to treatment, access to preventive care, access to holistic care and preventive program that could potentially explain some of the differences. Different healthcare sectors, different healthcare systems, private, public, and so on. That could also be an influential factor. And in terms of whether we will need risk prediction models specific for one country, so the short answer in the ideal world is yes, because again, we could argue that a model for country A will not be ideal for country B, but that's probably in practical terms not feasible or not possible. So that's why we recalibrated the model for every country. Again, and we can go as granular as we want. We could say we need model for people in one region, in one country, and another model for another region because they're very simple, they're very different, or they have very different access to healthcare and so on. But it all comes down to what is feasible and what could actually be done with the resources we have now.
One of the ideas that's got some currency in the US is to use poly pills. So pills that include both an antihypertension agent and perhaps a lipid lowering agent. Is there discussion about using polypills in Latin countries?
Yeah, that's true. I do not know if there are ongoing discussions to actually include that. I do think one of the challenges with that approach, though, is price and access, fabrication, manufacturing, shipping to the region. In general, these polypills are not much available across countries. Sometimes they are, in terms like combining different antihypertensive medication, but not so much when they actually combine antihypertension and lipid lower medication and so on. So that's going to be one of the big challenges. Yeah, that's going to be one of the big challenges.
All right, I want to thank you, Dr. Carrillo-Larco, for your presentation today. I want to thank our attendees for their questions. As I mentioned earlier, we will be posting the slides and recording of today's presentation on our website in the next few weeks. I want to thank everyone for joining today's lecture. Thank you.
Thank you so much.